Hi everyone, Ollie here and welcome back to the channel once again. Today we're going to be trying out a whiteboard tutorial format and talking about the optic pathway. This is one of the most basic elements of neurology that you'll need to be able to understand in order to comprehend some of the pathologies that you might see in exams or on the wards. Now, just so we have some learning objectives, we are going to be discussing the anatomy of the visual pathway. We will attempt to understand the basis of the visual fields. We will cover the consequences of damage to any part of the visual pathway. And we will also be discussing the various medical conditions that can lead to this damage. If that all sounds good, we'll begin. So let's just start with some basics. If we imagine that these are our two eyes with pupils looking straight ahead, so this is our right eye and this is our left eye, helpfully labelled. Now what we have to imagine is that for each of our left and right eyes independently, we split what they see into two what we call visual fields. And you can think about this being simply what's to the left and right of each of your two eyes, if that makes sense. So just starting with the left eye, your left eye can see things that are to the left of it and things that are to the right of it. So we're going to colour in the things that are to the left of your left eye in red, and this square here is what your left eye sees, if you imagine that. And sticking with the left eye, we're going to colour the other half of the field of vision of your left eye in blue. And these are what we call the two visual fields of the left eye. So this blue one over here is what we call the nasal visual field, because between your two eyes, as I'm sure you're aware, around here somewhere sits the nose. So the visual field of the left eye closest to the nose is called the nasal field of vision. The red side of the left eye, because it's on the outside and therefore closer to the temporal bone, we call the temporal field of vision. So now coming across to the right eye, we're going to colour the nasal field of the right eye in red and the temporal field in blue, and you'll see why we've done that in a second. So there we go. Just to match this up for our left eye, which are matching these two here, things on the left we see on the left, things on the right side of the left eye we see on the right side. Same for the right eye, things on the left side or the nasal side of the right eye we see on the left, things to the right side of the right eye we see on the right. This is fairly sensible. So we've got all this light that's coming in through the pupil and hitting the back of the eye in the space known as the retina. And what you have to imagine here is that because light travels in straight lines, always, the light that's coming through the pupil from the left side of the left eye is going to come through and strike the back of the eye on the right side, because it's got to strike in the opposite direction, if that makes sense. So if this is our light beam coming in, it comes through the pupil and will impact the retina on this side. And we'll put the retina for the nasal field here in. So once again, light comes through from the right hand side of the left eye and strikes the retina on the left hand side. And that's exactly the same for the right eye. And the reason that this is important is that it means that each of your eyes can build up a complete picture of what's in front of you independently. If I get rid of the left eye, your right eye can still see things that are to the left hand side of you through its nasal field and things that are to the right of you through the temporal field. You don't need the left eye to see things on both sides of you. And the same is obviously true for the right hand side. Basically, if you're struck blind in one eye, you can still see all the things that are in front of you, albeit with reduced depth perception because we don't have this crossing over here. So now that we've detected our light coming in, it's got to actually go somewhere. And this happens via the optic nerves, which pass through a small hole on each side called the optic canal, which is just a small hole in the sphenoid bone that allows the optic nerve to come through. And they've now entered the cranium and they're in the middle cranial fossa in the skull. So something quite cool now happens here where the nasal fibres from each side will actually cross over and track to the opposite side. And this happens at a point called the optic chiasm, which simply means to cross over or to decussate. And just to clarify, by nasal fibres I mean the medial retinal fibres from each side. The temporal light on the left eye comes through the pupil and strikes the nasal or medial retina, and that's then carried by the medial fibres through the optic canal in the sphenoid and crosses over to the right hand side of the brain. The same happens on the right hand side, so the temporal field of vision, which we can see here in blue, comes through, strikes the medial retina of the right eye, and then tracks across through the chiasm, crossing over to the left hand side. So to reiterate once more, the nasal or medial fibres carrying the temporal visual fields have crossed over, while the temporal fibres on each side have actually remained ipsilateral, so they're carrying the nasal fields coming through, striking the temporal retina, which stays ipsilateral and doesn't cross over. And this is really important for certain pathologies, which we'll discuss towards the end. And now here, these sets of fibres join to form the optic tracts on either side. So the left optic tract contains information from the left temporal retina, which stayed ipsilateral, as well as the nasal fibres from the right eye, which crossed over at the chiasm. The right optic tract, on the other hand, consists of the right temporal retina and the left nasal fibres, which again crossed over. And from here, the optic tracts simply travel backwards to reach a point called the lateral geniculate nucleus of the hypothalamus. And just think of this as a little relay station where some very basic visual processing takes place, but it simply tells the fibres where to go, where to send their information. And now we're moving towards the caudal end of the brain with the optic radiations, which will carry us through to the visual cortex. And just as before, where we split the visual fields into left and right, we now have to think about up and down, the top and bottom of the visual fields. And this happens for just the same reason as before. If this is our eyeball here and this is the retina at the back, light coming from an inferior direction will strike the retina at the top, and light coming from a superior direction will strike the inferior retina at the back, which is what leads to this separation. And this is actually really clever because the brain sends these fibres for up and down through two completely different pathways to keep them separate. So from the lateral geniculate nucleus, remembering in the hypothalamus, the superior optic radiation carries information about the inferior field of vision. It might be more helpful just to redraw what I mean here. So the eye at this point is now split into quadrants. Before it was split into left and right, now we've got up and down as well. So we have the superior optic radiation, which is carrying information about the inferior quadrant. So all the information that's coming to the right lateral geniculate nucleus is information about things that are on the left-hand side of us. If I bring this down slightly, we have the left-hand side of us over here is coming in through this fibre. Information that's on the left side of the left eye is coming in from over here through this fibre. So this is all left-sided light information that's coming down. Now we're splitting it into up and down, so the superior optic radiation is carrying this part of the vision. And this travels through the parietal lobe. The lower or inferior optic radiation instead carries information about the superior part of the vision over here and travels through the temporal lobe. And you might also hear this pathway referred to as Meyer's loop, specifically talking about the inferior optic radiation. And then to terminate the visual pathway, all the fibres will reach the visual cortex in the occipital lobe at the back of the brain. And it's here that all the information from all the nerve fibres that have come in are assembled, and then this is what we perceive as vision. So there we go, there's our complete pathway. Now we're going to talk about what happens when things go wrong. Damage to the optic pathways can cause a variety of kind of subtle and interesting visual results. And we'll talk about some of the more common ones here. So what we'll do here is I'll draw two big eyes. So once again we've got our left and right, and these are going to be our visual fields split in half. For the left eye we have our temporal and our nasal fields, then for the right eye, nasal and temporal, remembering that the nose would be in the middle somewhere. So to start with, quite a simple one, we simply have a disruption to the optic nerve where I've put this line here. This simply results in one-sided blindness because although light is hitting the retina in the same way as before, if there's a disruption or a lesion here to these nerve fibres, the information from the retina can't communicate with the nerves posterior to this point, so the brain doesn't perceive anything. And because this is a lesion of the right eye, we simply get complete one-sided blindness. The right eye doesn't see anything, so this is total blindness of the right eye. And there's a few things that can cause this. You might see it as a result of something like glaucoma, a stroke or an infarction to the blood vessels supplying the eye or the optic nerve, or something like an optic neuritis, inflammation of the optic nerve itself, preventing that information from getting through. So just so we understand, a lesion to the optic nerve on either side prevents the signals from that eye reaching the visual cortex in the caudal brain, so we perceive nothing from the affected eye. But what about if we were only to damage one side? So let's say here. So we haven't damaged the fibres on this side, so this could be damage to the optic nerve on this side or to the retina here. Well, if we think about what information this tract is carrying, this is why I love neurology, it's just like circuit diagrams. So these nasal fibres from the nasal side of the retina of the right eye are receiving the temporal visual field, so it's this information that won't be carried back to the visual cortex. So we come over to our right eye, we are going to lose the temporal field, so this area becomes knocked out. And now we're going to get into some of the terminology because this is a right-sided, because it refers to the right eye, temporal, because our problem concerns the temporal field of vision, hemianopia. So anopia, not able to see, hemi, half. So we have a right-sided because it's to do with the right eye, temporal because we've lost the temporal field, hemianopia because we've lost a full half of our vision. But crucially, the left eye is unaffected. But remember, this is what the patient sees. So if they close their right eye, they'd be able to see okay with the other eye. But if they were to close their left eye and only leave their right one open, they wouldn't perceive things to the right side of them. And that would have similar causes as things that would damage the optic nerve more directly, as we discussed before. Now, a lesion in the optic chiasm here, where our nerve fibres cross over, is a really interesting example, and it's a really good one to know for exams. So you'll hopefully remember that the pituitary gland sits in the sella turcica, which is a small saddle-shaped depression, sella turcica, Turkish saddle, in the sphenoid bone, which happens to sit around here. I said before that the optic canal was a hole in the sphenoid bone itself, which places the pituitary gland and the sella turcica in this area inferiorly. So if a tumour were to develop in this kind of area, which would classically be a pituitary adenoma, because there's just bone beneath the pituitary gland, these tumours will cause an expansion upwards, which in turn puts pressure on the optic chiasm. And this will knock out the decussating fibres, but not the ipsilateral fibres, because they're more laterally placed. So if we look at our wiring diagram, as it were, we can see that the only fibres in the middle are the nasal retinal fibres for each eye, those that are carrying the temporal visual fields. So we're going to lose the temporal field for both the left and right eye, so we only maintain the nasal fields. And this visual field disturbance is again a classical presentation for this kind of tumour. This is called a bitemporal hemianopia. Bitemporal because it's happened in both eyes, bitemporal because we've lost the temporal field, and again it's a hemianopia because we've lost a semicircle of vision from each complete eye. We've lost half the visual field. So there are three types of tumour that I've seen personally, cases where people have had these and have seen the surgery. to remove them. The first is a pituitary adenoma, which is the most common. The second is an olfactory groove meningioma. And the third is a craniopharyngioma. So these are the three types of tumours that I personally tend to associate with this presentation. So now the optic tracts are carrying the assembled vision, if you like, for each half of the body, because they have information about what relates to either side of you. Now the optic tracts here are carrying information about what's on either side of you. They each contain a complete vision of what your body sees either side. A lesion here, for example, will cause us to lose half of our vision on one side, but for both eyes. And again, we can work it through from our diagram. So these are the two fibres that we've lost, these two red ones. So the right-sided one contains the nasal visual field for the right eye. That's been lost. What about this other one? This contains the temporal field for the left eye. So let's mark that on our diagram. So we've lost the right nasal field, and we've lost the left temporal field. So you can see we've lost the left side of the vision for each eye. And what we have here is this is a left-sided, because it affects the left side of the vision for each eye, homonymous, because it affects both eyes in the same way. We've lost the left side for both eyes. Once again, hemianopia. So this is a left-sided homonymous hemianopia. And these homonymous hemianopias are caused by damage to the optic tracts. And these might be caused, as all things in the brain are, by strokes, maybe some kind of neoplasm malignancy, some sort of infection, or maybe even damage during surgery. And this type of vision loss can also be an aura for some people of an impending migraine, an aura being a sign that someone is about to experience the pain that comes with a migraine. So that's the optic tracts dealt with. Now we've got to talk about the optic radiations, the posterior part of our pathway. And we said before that the optic radiations are divided into an upper and lower visual field component. So now we're dealing with quadrants. And very inconveniently, the superior or upper optic radiation will carry the inferior field of vision. The inferior radiation or Meyer's loop in the temporal lobe carries the superior part of the visual field, because of what we said about how light strikes the retina from the opposite angle. So let's say that we put a lesion here through the superior or upper optic radiation in the parietal lobe. Because the right upper optic radiation, remembering we're in the right side of the brain here, is carrying information about the left side of us, this is going to knock out the inferior left quadrant for both eyes. And the naming gets a tiny bit simpler again. This is called a left-sided inferior quadrantanopia, because we've lost the left inferior quadrant. Because we're in the right side of the brain, which is carrying information about what's on the left-hand side of us, and we've knocked out the inferior part of the vision carried by the upper optic radiation. Try and get your head around that. Equally, if we put a lesion here in the inferior optic radiation, Meyer's loop travelling through the temporal lobe, because this is carrying information about the left-hand side of us, but it's carrying the upper part of the visual field, we will lose the upper quadrant instead. And we will have a left superior quadrantanopia, just like before, but for the upper part. And this usually happens because of a stroke in the deep branches of the middle cerebral and posterior cerebral arteries, which supply these parts of the brain. And something it's worth noting is that this line which separates the upper and lower quadrant in the visual fields is very, very sharply defined, and this is because of the anatomical separation of the fibres. Whereas with the left and the right side, there's not always the kind of symmetry and congruence. So to reiterate, this line separating the quadrants is very sharp because of the anatomical separation of the fibres through the parietal lobe and the temporal lobe, whereas because the information for the left and right side of the visual fields travel together in such close proximity, you don't get that same sharp divide. in the visual fields between the left and right sides. So we're on the last leg now, the final visual pathology to talk about. This is the occipital visual cortex in the occipital lobe and the posterior part of the brain. The fibres from the optic radiations are reassembled back together to provide our complete field of vision. So damage here actually presents very similarly to damage here, because it's the same total sum of information that's come in here, travels separately through these fibres and is then put back together here. So let's say we've got damage here where the fibres are reassembled in the visual cortex. What we will actually have is a left-sided homonymous hemianopia again, just as we had here, because we've lost information about the left-hand side of the body coming in. It's been reassembled, we've now got a lesion here, but something interesting occurs. Let's just say, for argument's sake, that you've had a stroke in the posterior cerebral artery in the calcarine branches, which is what supplies this area of the occipital lobe. That would knock out these fibres and you get this presentation. However, with a slight difference, what you get is this effect, which is what's called macular sparing. This is because this part of the brain actually has a double vascular supply from the middle cerebral artery and the posterior cerebral artery. So what we have, if we try and name this, again is a left homonymous hemianopia with macular sparing. And that actually concludes this video, guys. That's all the visual field pathologies that I have to talk about today. I really hope you've enjoyed this video. This is one of my favourite areas of neurology to talk about and to teach, the visual fields and the optic pathway. If you found this video useful, what I would really appreciate is if you can go to the link in the video description and fill out the feedback form for this video. These videos are all provided for free, as is everything on my channel and on my website, but it would really help me out if you could go and fill out a feedback form. This will just be a few questions about how well I did teaching the topic, how well you understood our learning objectives, and what improvements you'd like me to make next time. And once you've filled out that form, that will give you access to an A4 sheet where I've made a summary of everything you need to know from this tutorial, as well as an ANKI deck, which is full of questions that can help you test yourself on the things we've covered and cement it in your long-term knowledge. Please be sure to hit that like button for me, leave a comment, subscribe to the channel if you'd like to see more videos just like this, and go and take care of yourselves. I'll see you next time. Bye-bye.